Good morning, ladies and gentlemen. First of all, it's really a great pleasure for me to be here and a great honor too. So, Robbie, thank you for inviting me here. So, what I'm supposed to do within the next few minutes is to tell you something about the diagnostic of isolated cleft palate and real challenge in our daily diagnostic. So, you see here the detection rates of orofacial clefts from recent bigger studies, and you can see, as you can see here, the detection rates for cleft lip palate are pretty good, increasingly tendency over the years, whereas the detection rates for cleft lip palate are, I would say, more than bad. So, where's the problem? The main problem are the surrounding osteostructures, causing strong shadowing and avoiding the assessment of the palate. Two other points are the dome-shaped structure of the palate and the fact that hard and soft palate are not in one plane. So, what's to do? So, the first and the most important step in the diagnostic of these malformations is to identify those fetuses they might have isolated cleft palate. Regarding the pathophysiology of isolated cleft palate, all fetuses with micro and/or retognathia are suspicious to have such a malformation, but you can't trust in this alone. You see, these are all profiles from fetuses with isolated cleft palate, and you see a very typical profiles with severe retro and micrognathia from children with Pierre syndrome, but they are also quite normal profiles. You see here, you wouldn't expect a cleft. So another indicator suitable for retina diagnosis would be helpful. And there's one, and you can use it. And the key is the uvula. You see here. So to understand the following technique, you have to know some important points. During the embryological development, the closure of the secondary palate here always starts at the incisive foramen and goes continuously in the dorsal direction. This is the same principle as the closure of a zipper. So, the normal condition is a completely closed zipper, here hard, soft palate ending with the uvula. In cases of isolated cleft palate, the zipper is more or less closed. The mildest form is the almost completely closed zipper, only affecting the uvula bifida. So, you see, the always affected structure in all cases is the uvula. And the other way around, that means a normal uvula rules out isolated cleft palate. Another point, please memorize this, I come back later, is that the defects of the soft palate are always lying in the midline. So how to get the uvula? The easiest way is starting with a transthalamic section you see here, you use for the biometry of the head. What you want to see is here, the soft palate and the uvula. Now, from this plane, you move the transducer parallel to this plane in the caudal direction. Here opens another pharynx, soft palate. Sometimes you have to tilt the transducer a little bit to get it on its full length. If you can't find the uvula in this way, turn into a coronal section, scanning the pharyngeal space and searching for the uvula using the epiglottis as the landmark. So far the theory. Now, you see it here, the transversal transthalamic section. So we move now the transducer parallel in the caudal direction. Here, nasopharynx, soft palate, and the uvula. So, because of its typical echo pattern, these two echogenic lines with a hypoepigenic space between, we named it the equal sign. It was an idea of my wife, by the way. So, the coronal section, here the head. So we are searching here the epiglottis, and upon the epiglottis, you see here the equal sign again, the uvula. So, if you see the uvula, the unremarkable uvula as an equal sign, be sure that the palate is intact. The non-visualization of the uvula doesn't prove a cleft, but it's an indicator that it could be. Now it's on you to sort out whether there's a cleft or not. So please remember now the point I mentioned before, that the defects are lying in the midline, so check the soft palate in the mid-sagittal section. So, to be honest, I can't understand why I didn't realize this structure all years before, despite its presence. Now I'm used on it, and I see it immediately. But it's a kind of training. If you want to perform this kind of diagnostic, you have to be very careful with the intonation angle in order to avoid misinterpretations or misdiagnoses. You see here a profile while slightly changing the intonation angle. So we wait. So more coming from above, you can't see the soft palate here. And if you change, coming more from below, the soft palate becomes visible. I show you here an example in higher age of gestation with a stronger shadowing. What you have to do is, you have to use the window between the both jaws here. Then you can clearly identify the soft palate, even if the mouth is closed and the soft palate is directly close to the tongue, here ending with the uvula. So, under optimal conditions with fluid between tongue and the soft palate, you can learn a lot about the physiology of swallowing and of tongue control, the interaction here between the tongue and the soft palate in order to avoid glossoptosis. And note, in neutral or extended position of the head, the tongue is never touching the posterior wall of the pharynx. So far the theory. Now I will show you some examples. So this was a child with a moderate retrognath here, and here I'm searching for the uvula within the pharyngeal space. You see here the epiglottis, the tongue, posterior wall of the pharynx, and I'm not able to find here the uvula. So that's an indicator that a cleft could be. So checking the mid-sagittal section, you see two things. At first, clearly the absence of the soft palate here in the midline, indicating the isolated cleft palate. And you see another thing. During swallowing, you see that the tongue is touching the posterior wall of the pharynx, indicating the clinical problem of a glossoptosis. And this becomes clearer if you see the fetus yawning here. You see this broad glossoptosis here in comparison to the normal findings and the completely absence of the soft palate. So we were able to make the diagnosis of an isolated cleft palate. And you see here the confirmation after birth, in this case an extremely wide cleft here. You have here the view directly on the vomer and the closed lip and alveolus. So, in second example, this was a totally unremarkable fetus, but I couldn't find the uvula here. So, checking the mid-sagittal section, you can clearly demonstrate here the absence of the soft palate here in comparison to the normal findings, and in this case we were able to make the diagnosis isolated cleft palate. So this is the confirmation after birth, so I want to say a quite normal cleft. So here now is the head is lying here on the right side. I'm searching for the uvula, and I cannot find the uvula here in this case too. So, checking the midline, here you have another situation. You see a part of the soft palate, but it's markedly too short and it's not ending with the uvula. So here we made the diagnosis of an isolated cleft only in about half of the soft palate, a smaller cleft, and the confirmation after birth. So to come to the end, I want to show you some data. Since using this technique, we examined now about 7,000 patients. We were able to diagnose 8 cases of isolated cleft palate. To our knowledge now, we missed no cleft. And furthermore, you can use this technique for your diagnostic of cleft lip palate too. And in our series, we had 18 cases of cleft lip palate, and we were able to predict the involvement of the palate correctly in 17 of these 18 cases. And together with other colleagues using this technique too, we collected now 21 cases of prenatal diagnosed isolated cleft palate. So I wish I encouraged you to learn and to use this technique to come finally to the point to feel like he feels, relaxed and self-confident in the diagnostic of orofacial clefts. Thank you very much.